Hello, pharmacy friends. Let's dive right into one of the most common disease states affecting our communities, diabetes mellitus. The most recent clinical guidelines for diabetes is the 2018 American Diabetes Association Standards of Medical Care in Diabetes. This guideline clearly outlines the diagnostic criteria for diabetes, but it is important to understand a few important terms first. Fasting plasma glucose is defined as a blood glucose measured after a fasting state of at least 8 hours. The 2-hour 75-gram oral glucose tolerance test is a test that can be performed to measure the anticipated blood glucose level after a meal, also known as a postprandial glucose level. And the A1C is a measurement of blood glucose control over the last 3 months. It is essentially the percentage of hemoglobin that is coated with sugar. Now we can define prediabetes as a fasting plasma glucose of 100 to 125 milligrams per deciliter, a blood glucose of 140 to 199 milligrams per deciliter following an oral glucose tolerance test, and an A1C of 5.7 to 6.4%. Diabetes, then, is defined as a fasting blood glucose greater than 126 milligrams per deciliter, a blood glucose greater than 200 milligrams per deciliter following an oral glucose tolerance test, and an A1C greater than 6.5%. Symptoms of diabetes include polyuria or increased urination, polyphagia or increased hunger, and polydipsia or increased thirst. These are commonly known as the 3 Ps of diabetes. Other symptoms include blurry vision, as diabetes is a major preventable cause of blindness, fatigue, weight loss, and slow wound healing. Type 1 diabetes occurs as a result of autoimmune destruction of the beta cells in the pancreas. This leads to decreased insulin production and low body weight due to impaired insulin production. Insulin is important because it helps our bodies to clear glucose in the blood and to store it in the form of glycogen. Type 1 diabetes tends to present earlier in life, but type 2 diabetes typically occurs later in life and is a result of insulin resistance, combined with decreased insulin production. Many patients with type 2 diabetes have something called metabolic syndrome, which can result from high blood pressure, high blood sugar, excess body fat around the waist, and dyslipidemia or high cholesterol levels. Our focus for this video will be type 2 diabetes. Uncontrolled diabetes can cause damage to many organ systems in the body. These complications can be divided into microvascular and macrovascular complications. The microvascular complications include retinopathy, nephropathy, and neuropathy. Neuropathy can affect the nerves in the hands and feet, can contribute to impotence, and even can cause slowed gastric emptying. Macrovascular complications can include myocardial infarction, peripheral artery disease, and stroke. There are many factors that can increase a person's risk of developing diabetes. These include age 45 years or older, unhealthy diet and obesity, family history, especially if a first-degree relative had diabetes, race, including African Americans, Alaska Natives, American Indians, Hispanics and Latinos, Hawaiians, and Pacific Islanders, high blood pressure, gestational diabetes, which is a type of diabetes that occurs in pregnancy, sedentary lifestyle, and excessive alcohol consumption. As pharmacists, it is always important to look for drugs that can raise blood glucose. These include second-generation antipsychotics like olanzapine and quetiapine, corticosteroids, fluoroquinolones, beta blockers, statins, and thiazide and loop diuretics. Now take a look at what mechanisms would increase blood glucose in the body. First, when we eat a meal, carbohydrates, which are essentially sugars, will increase the amount of glucose in our blood. The liver stores glucose in the form of glycogen. When this is broken down through a process called glycogenolysis, glucose in the blood increases. As mentioned previously, insulin is responsible for clearing the glucose from the blood. So if less glucose is being produced, blood glucose levels will rise. Finally, our muscles and our other organs must be sensitive to insulin in order for glucose to be taken up for use peripherally. Hence, insulin resistance, which occurs in type 2 diabetes. The ADA recommends that patients with diabetes maintain an A1C of less than 7%, a preprandial or prior to meals plasma glucose level between 80 and 130 milligrams per deciliter, and a peak postprandial or 2 hours after a meal plasma glucose level less than 180 milligrams per deciliter. And for hospitalized patients, the blood glucose goal is more lenient and should be maintained between 140 to 180 milligrams per deciliter while patients are acutely ill, as stress can increase blood glucose and the risk for hypoglycemia is high. We also need to make sure that our patients with diabetes receive their appropriate vaccines. These include hepatitis B, influenza, and the pneumococcal vaccine. As we moved on to treatment, lifestyle modification should be encouraged in all patients with diabetes. Patients should lose weight if appropriate, should stop smoking, should exercise 150 minutes per week or 5 days per week, 30 minutes each day, and should maintain a healthy diet. These are all key in reducing the risk of complications due to diabetes. All patients with diabetes should be treated comprehensively for their disease to further reduce the risk of diabetes-related complications. Patients should always try to maintain a blood pressure less than 140 over 90 millimeters mercury and less than 130 over 80 millimeters mercury for patients who are at high risk of cardiovascular disease per the ADA guidelines. Please note that this recommendation differs from the 2017 ACC-AHA guidelines, which recommend that all patients with hypertension should maintain a blood pressure less than 130 over 80 millimeters mercury. In addition, the patient should annually be tested to determine if the patient has albuminuria or excess albumin in the urine. This is indicated by a urine albumin to creatinine ratio of greater than or equal to 30. Patients with diabetes should have an annual comprehensive foot exam performed by their provider, and the patient should examine their feet daily to check for wounds that may not have been felt due to diabetic neuropathy or wounds that are not healing properly. Patients should also get an annual dilated eye exam to screen for retinopathy. And patients should monitor their blood glucose at home to assess blood glucose control. Pharmacists should encourage patients to keep a blood glucose diary to help guide therapy decisions. For patients with an A1C less than 9%, we will first recommend metformin, which we will discuss shortly, in addition to lifestyle management. Then, we will reassess the patient in 9 months when we can get another A1C. If the A1C is greater than or equal to 9%, but less than 10%, we initiate metformin in addition to another anti-diabetic agent and lifestyle changes. And we will again reassess this patient in 3 months. And for a patient who has an A1C greater than or equal to 10%, is markedly symptomatic, or has blood glucose greater than or equal to 300 milligrams per deciliter, we will go straight into combination injectable therapy, typically in addition to metformin. These patients will need to be reassessed much sooner than 3 months because of the risk of hypoglycemia with injectable therapy. To choose the right treatment for our patients, we must look at several factors. including their A1C, the presence of clinical ASCVD, which includes coronary artery disease, myocardial infarction, stroke, and peripheral artery disease. For patients with clinical ASCVD, we want to initiate a drug with ASCVD benefit, including an SGLT2 inhibitor or a GLP-1 agonist. We will discuss these drug classes further in just a bit. For patients with heart failure or CKD, we will want to initiate an SGLT2 inhibitor. Other factors that will impact our choice of drug therapy include the patient's weight, the cost of the medication, the patient's visual acuity and dexterity when using injectable products, and even their history of thyroid cancer or pancreatitis. Drugs for diabetes are either oral or injectable. Our oral medications include metformin, SGLT2 inhibitors, DPP4 inhibitors, thiazolidinediones, and sulfonylureas. Injectable medications include insulin and GLP-1 agonists. Of note, there was a recent formulation of a GLP-1 agonist that was recently approved, but most of these are injectable. Metformin belongs to the class biguanides. Metformin activates AMP kinase and decreases hepatic glucose production, increases insulin sensitivity, and increases absorption of glucose. The target dose of metformin is 850 to 1,000 milligrams twice daily. It can lower A1C by 1.5% on average and can provide benefit in lowering ASCVD risk. The most common side effect of metformin is gastrointestinal upset, which includes nausea, diarrhea, and abdominal cramping. However, these side effects tend to go away in a week or two of continued use. Metformin can also deplete vitamin B12 levels, which warrants supplementation, and may even help patients to lose weight. Metformin has a black box warning for metabolic acidosis, which is a severe but rare condition that can be precipitated by renal impairment, which is why we do not want to initiate metformin when the GFR is between 30 and 45. Finally, metformin is one of our cheaper options for diabetes. Sulfonylureas are another class of medications. These medications work by stimulating the release of insulin from the beta cells of the pancreas without needing to be stimulated by glucose. Examples of sulfonylureas include glipizide, glimepiride, and glyburide. Because glimepiride has an active metabolite that is renally cleared, this medication is often avoided in the elderly and in those with renal impairment. The most notable side effect of sulfonylureas include hypoglycemia. They also include nausea and weight gain. Patients should take these medicines with meals in order to reduce the risk of hypoglycemia. But fortunately, these medications are inexpensive. Thiazolidinediones, also known as TZDs, are a class of medications that work by increasing insulin sensitivity by activating nuclear transcription factor PPAR-gamma. Examples of TZDs include pioglitazone and rosiglitazone. Specifically, pioglitazone may provide benefit in patients with ASCVD. Side effects of TZDs include bone fractures, fluid retention, weight gain, increased LDL with rosiglitazone, and bladder cancer with pioglitazone. Due to their water retention properties, TZDs have a black box warning for exacerbation of heart failure and should not be used in patients with New York Heart Association Class 3 or 4 heart failure. This class of medications is also inexpensive. DPP4 inhibitors work by inhibiting the DPP4 enzyme, which normally breaks down incretins that stimulate a decrease in postprandial glucose. By inhibiting this enzyme, incretin activity is increased. Through this mechanism, they increase glucose-dependent insulin secretion and decrease Glucose-dependent glucagon secretion. Glucagon helps to increase blood glucose. Examples of DPP-4 inhibitors include sitagliptin, saxagliptin, linagliptin, and alogliptin. These medicines are generally well tolerated, but can increase a person's risk of acute pancreatitis, joint pain, and heart failure with saxagliptin and alogliptin. This class does not cause weight gain or weight loss. However, these medicines are rather expensive. SGLT2 inhibitors inhibit sodium glucose transport protein 2 in the proximal nephron to decrease glucose reabsorption. Canagliflozin, dapagliflozin, and empagliflozin all belong to this class of medications. Canagliflozin and empagliflozin not only provide benefit in ASCVD, but they also provide benefit in heart failure. For this reason, these medications are often preferred, but they do come with some side effects. Specifically, canagliflozin can increase a patient's risk for bone fractures. All drugs in the class can increase a patient's risk for diabetic ketoacidosis, specifically because typical DKA symptoms may be masked. They can also cause genitourinary infections like urinary tract infections, dehydration, increased LDL cholesterol, but they can help a patient to lose weight. With canagliflozin, there is a black box warning for increased risk of amputations, which can be concerning since diabetic patients are already at an increased risk for this. Furthermore, these medications can be expensive. Our last class of medications are the GLP-1 agonists. These work by activating GLP-1 receptors and incretin receptor, thereby increasing glucose-dependent insulin secretion. This class includes exenatide, exenatide extended release, liraglutide, dulaglutide, lixisenatide, and semaglutide. Exenatide is administered twice daily, but its extended release formulation is administered weekly, which can be helpful in maintaining good adherence. Liraglutide is a once-daily injection, and per the LEADER trial, it can help to improve ASCVD risk. Most of these medications are injectable except for the new form of semaglutide, which is oral, and thus can cause injection site reactions, acute pancreatitis, gastrointestinal upset, including gastroparesis, and weight loss. There is a black box warning for thyroid C-cell tumors, except with exenatide and lixisenatide, and these are a more expensive class of medications. Insulin is a heavy topic. I will provide a very brief introduction in this video. In a patient requiring insulin therapy, we always want to fix the patient's fasting or basal glucose levels first. So, we initiate a basal insulin dose of 10 units per day, or 0.1 to 0.2 units per kilogram per day. We can then titrate the dose 10 to 15% or 2 to 4 units once or twice weekly as needed to reach the fasting blood glucose target. Hypoglycemia is a major side effect of insulin therapy, but insulin is the most effective method for lowering blood glucose. If the patient experiences hypoglycemia, then we need to be sure to address the cause or decrease the dose by 4 units or 10 to 20%. If patients need additional blood glucose control, we can either add one rapid-acting insulin, a form of mealtime insulin, before the patient's largest meal of the day, add a GLP-1 receptor agonist, like liraglutide, or change the patient to premixed insulin before breakfast and dinner. In this case, we would not want to initiate this type of insulin on top of basal insulin. If adding rapid-acting insulin is not sufficient for blood glucose control an additional dose of rapid-acting insulin can be added to another meal. For example, one injection before breakfast and another before dinner. Keep in mind that this is in addition to basal insulin, which is taken at night. Or, for our patients using premixed insulin, we can add another dose of premixed insulin before lunch. Clearly, we have many types of insulin. Our basal forms include glargine, detamir, and degludec. Our rapid-acting insulins include Lispro, aspart, glulicine, and inhaled insulin, which is rarely used. Regular human insulin is a form of short-acting insulin. And our premixed insulin comes as an injectable combination between a longer and a faster-acting insulin, with the highest concentration being the longer-acting insulin and the lower concentration being the faster-acting insulin. In patients with type 1 diabetes, insulin is necessary. We initiate insulin in these patients by calculating their total daily dose using 0.6 units per kilogram per day, dividing that total daily dose into 50% basal and 50% bolus, or the shorter-acting insulin, and finally dividing the bolus dose further by 3 to find the bolus dose for each meal. We call this basal bolus dosing of insulin. If the patient is using NPH and regular insulin, 2/3 of the total dose will be NPH and the remaining 1/3 will be regular insulin. Hypoglycemia can be a very serious adverse effect of diabetes medications. Hypoglycemia is defined as a blood glucose of less than 70 milligrams per deciliter. Signs and symptoms of hypoglycemia include sweating, confusion, sleepiness, dizziness, hunger, irritability, and pale skin. Hypoglycemia can be treated by having the patient check their blood glucose and then consuming 4 to 5 glucose tablets, 1 tablespoon of sugar or honey, 4 ounces or 1/2 cup of orange juice, or 4 ounces of non-diet soda. We really need that sugar content. The patient will then wait 15 minutes and then recheck their glucose to make sure it is above 70 milligrams per deciliter. If they are still hypoglycemic, they can repeat these steps again. However, if a patient is unconscious, glucagon will be needed. And patients who are at high risk for hypoglycemia may need a prescription for glucagon on hand. As mentioned previously, patients with diabetes are at a higher risk of ASCVD. High-intensity statins should be prescribed to patients with clinical ASCVD, and a moderate-intensity statin should be recommended for patients who are older than age 40 and those who are less than age 40 with ASCVD risk factors, including a family history of ASCVD, hypertension, dyslipidemia, smoking, and albuminuria or chronic kidney disease. Before considering aspirin therapy, we must assess a patient's bleeding risk. But for many patients, aspirin is appropriate, especially in patients with a history of ASCVD or those who are 50 years or older with an additional ASCVD risk factor. For patients with ASCVD and a contraindication to aspirin therapy, clopidogrel 75 milligrams per day may be appropriate. Lastly, many patients' disease is complicated by diabetic neuropathy, which may manifest as pins and needle-like or burning pain in the extremities. Pregabalin, gabapentin, and duloxetine can be used to help patients with this type of pain. Duloxetine may be particularly helpful for patients who also have comorbid depression. Guys, you made it to the end again. Thanks so much for joining me on today's talk on diabetes. I hope you learned a lot. Please subscribe, like, comment. I'm open to suggestions and happy to answer any questions you have. Thanks for learning with me. We'll see you next time.